Hello Sid, how are you?
Hello, I'm good, thank you very much.
So you're the latest edition of our interviews with ophthalmologists.
It's my privilege.
Thank you very much for today. So just start off with just tell us a bit about yourself.
So I'm Sidath, Wijetilleka, one of the consultant Vitreo-retinal surgeons here at Swansea Bay University Health Board. I also work privately for Sana Health in Samlet as one of the only private Vitreo-retinal surgeons around. Been here for 5-6 years as a consultant now, and yeah, it's been a privilege to work here.
Fantastic. First question is, why did you choose the Vitreo-retinal subspeciality?
So I always thought it's one of the best things to do in the eye. If you can, most people can only operate on, say, the anterior 1/3 of the eye,
right.
But if you can operate on the whole eye, like the full 3/3 of the eye, you're a bit more of a master of the eye and have a bit more dexterity when it comes to difficult, complex cases. Only about 10% of people, of ophthalmologists, go on to do vitreoretinal surgery, so it's quite a niche speciality, and there's only about, say, under 100 vitreoretinal surgeons in the UK, so it's quite rare. I think we've got about 6 of us in Wales who spread out across mainly the south who do it, so it's quite a niche subspeciality, but it is very rewarding as well when you can fix retinal detachments and improve people's structural eye problems, and it can make a big difference. I always thought if you just give patients drops and tell them to go home, you may not feel that fulfilled, but if you can make a big surgical difference to their vision, then they're often very grateful.
Amazing. First question is about operculums, and what is it, and do we need to refer any operculums?
So there's very good guidelines from the American Academy of Ophthalmology called Practice Referral Guidelines, and I encourage anyone to have a look at those online. They are very clear in sort of what they constitute as should be referred and shouldn't be referred. There's a multitude of peripheral retinal degenerations, including operculums, sort of aura base cysts, etc., lattice degeneration. We can talk about these in a moment. Essentially, an operculated tear is a break in from where the vitreous has essentially liquefied over the retina and has caused a retinal tear, but has let go of the retina itself, so there's no traction on the retina. So the biggest difference between a retinal tear that causes a retinal detachment and a retinal tear that doesn't is the traction on the retina from the vitreous. So if the vitreous has operculated, which means it's lifted away from it's caused a tear, but it's moved away from the retina, then that's a lot more safe and a retinal tear than one where there's no operculum, then that's likely to lead to a retinal detachment. So an operculated tear doesn't need to be referred in, essentially because we don't treat them. So, and that operculated tear may well have been there for many found incidentally, or may well have been present for some time. So we don't routinely treat them, and it's not recommended to treat them. The one thing we could do is treat them with laser retinopexy, but the problem with that is then that can then cause secondary problems like epiretinal membranes, etc., to form. So it's a risk-benefit analysis of what will you actually gain from doing some prophylactic retinal laser treatment to the operculated tear where there's no traction on it, and you can then develop other secondary problems from the retinal laser itself.
Fantastic. Another question come from the optometrist is PVDs with peripheral hemorrhages. Do we refer even if there's no evidence of a break? Or?
I would, yes. So if it's a hemorrhagic posterior vitreous detachment, that means there's got to be some sort of traction on one of the retinal vessels, which would probably cause the bleed. But it's very difficult to rule out a retinal tear. So the gold standard that we use as ophthalmologists is something called a scleral indented examination, where we use an indirect ophthalmoscope to then indent the sclera, and we can actually push in through the aura, all the way from the aura to the equator, to see if there is a retinal tear. And that's a unique skill set that I'm not sure if it's taught in optometry to do scleral depressed examinations there. But that's the gold standard for ruling out retinal tears. You've got a dynamic range of motion on the sclera and the retina with an indented exam, so you can rule out any peripheral retinal tears. That could be very difficult to see if you didn't do a scleral indented examination.
Next question is someone, again, similar story, of someone coming with flashing or floaters in a patient with no history of retinal tears or detachment. Can they get tobacco dust in that?
So tobacco dust is what we call, is actually an RPE cell. So it's the retinal pigment epithelial cells which are unleashed into the vitreous cavity from underneath the retina. So there's got to be a tiny break somewhere for actual tobacco dust to be present in the vitreous. Often people can get confused between red blood cells and tobacco dust. So tobacco dust looks like a Y-shaped brown pigment, whereas people may see red blood cells which look like little brown specks. Okay. They're very different in nature, but you have to really look carefully with a high magnification and so on to differentiate between the two. So if you do have tobacco dust, always refer in, because there may well be a retinal break somewhere, and it's better that it's checked with a proper scleral depressed examination.
Fine. And it's quite common, next question would be the lattice degeneration, which is also very common in a routine eye exam, seeing someone with lattice degeneration. What advice would you give an optom if they see a lattice degeneration during a routine eye exam?
So lattice is relatively quite common. About 7 to 10% of the population have lattice degeneration. Okay. Often people develop breaks on the edge of the lattice degeneration, so I'd probably look carefully at the edge of the lattice to see if there's a little hole or a break somewhere there. They can often be sclerosed vessels and other sort of pathology around the lattice, which could be of insignificant consequence. But if there's a retinal break and there's lattice, then we may have a lower threshold of treating that break, and maybe the lattice as well. But if there's no retinal tears and it's just lattice degeneration, that's generally quite common in myopic individuals or myopic retinas to have that. So I wouldn't worry about it too much. But the important thing is, once again, just always safety net. So say, look, advise the signs of a retinal tear, retinal detachment, flashing lights, floaters, dark curtains, any of those, get in contact.
Fine, fantastic. And the classic all-time question is when you're dilating a patient, obviously you add tropicamide, and what about phenylephrine? Do we add phenylephrine or without phenylephrine with the addition of tropicamide?
That's a good question. So it's a lot to do with the pharmacokinetics of how they work. Right. So tropicamide essentially is an anticholinergic substance. So it basically increases the parasympathetic drive to the eye. So whereas phenylephrine is a sympathetic agonist, so it increases the iris dilator muscle's activity. So the phenylephrine basically increases the dilation or the dilator muscle, whereas the tropicamide stops the constriction, essentially. The studies have been done to show 2.5% phenylephrine isn't as effective as tropicamide in the rate of dilation, it's in speed of dilation, or the maximum dilation achieved. However, 10% phenylephrine has been shown to be more effective than tropicamide. However, the best dilation is achieved when both of those agents are used together. So I'd combine it and do a phenylephrine and tropicamide dilated exam for maximum dilation of the pupil.
Fine. And how important is record keeping, would you say? Particularly when I've worked in an eye casualty, whenever we've seen a retinal tear, whenever we speak up, ask you about your opinion about it. You always stress the importance of record keeping. Yeah,
I've got a big interest in medical legal documentation, so it's incredibly important to essentially, if you think about if you catastrophize the situation and say the patient eventually takes you to court for missing a retinal tear. This was a case a few months ago. There's an optom missed a retinal tear and was taken to court later by a patient who went on to have a retinal detachment. And record keeping is really the gold standard of defensive medicine. And if you document no tobacco dust, the relevant negatives is the most important thing. And I think that's one of the biggest things coming from community to hospital optometry is actually documenting relative negative findings. They're saying no tobacco dust, no retinal break seen, indented examination done, posterior vitreous detachment present with no retinal tears. And then always safety net. So, say to the patient, advise on the signs of a retinal detachment and document in the notes that you've done that. Because then the patient, even though they may forget that you've said, I was told about the signs of a retinal detachment and they've forgotten what they were, at least it's in the notes and documented in the notes that it's present. And the other thing to say is always check the other eye. So, patients have two eyes, and if you find a retinal tear in one eye, statistically they're more likely to have one in the other eye as well, or develop one at some point. So it's always important to check both eyes thoroughly and document both eyes.
Fantastic, good advice.
And document the warning signs as well. So safety netting is incredibly important, especially with medical legal
jargon
stuff.
terminology. So epiretinal membranes, we talked about this yesterday, didn't we? We mentioned we had a patient yesterday. At what point would you refer in an epiretinal membrane, and what would you just leave it as it is and just monitor the patient?
Yeah, very good question. So distortion is the prime symptom of an epiretinal membrane, and that can be very difficult to quantify with a Snellen chart or the regular sort of charts we use to measure visual acuity. So it's really symptomatically of the patient. So the patient says, I've got distortion, my world's at 45 degrees, all my straight lines are blurred. Then, that's, but they can see 6'9". You think, well, hold on, does that, is a 6'9" a bad enough indication to refer in for epiretinal membrane surgery? I say it's all about the patient. If they're very symptomatic of distortion, but even if they're 6'6", you can say, look, you're symptomatic of distortion. Even though you can read 6'6" on the chart, it's maybe worth considering an epiretinal membrane peel. Nowadays, surgery is a lot more safe than it was even 20 years ago. So actually, the benefits people may get from removing their distortion or reducing their distortion by removing their epiretinal membrane can be very, very beneficial to the patient.
Fine. And last question is, we talked about macular holes. We saw one picture yesterday, macular hole. The waiting time, what is sort of waiting time here, and what sort of treatment is available for someone?
So generally, statistically speaking, a macular hole, if it's been present for more than 18 months, statistically it's less likely to close than if it was a fresh macular hole. So we try and get all our macular holes done within about 3 months from referral. So it's quite a journey from the patient, because often by the time they've gone to their optician, it may well have been present for a few months, the macular hole. So we try and work out actually how long since the initial presentation from the patient's point of view that was. So it's very helpful if you could document this patient has noticed distortion or a blur in their vision for a certain amount of time, or since this date. Then we can backdate that and try and work out how far from 18 months that patient is, and try and get their macular hole done within that time. But the waiting list at the moment on the NHS is about 3 to 4 months for that.
Thank you very much, Sid.
My pleasure.
Thank you.
Good. Thanks.